IVL window located 3 millimeters from the tip of the catheter. The IVL window contains saline, which enables energy transfer from the emitter to the calcium. The reinforced braided stainless steel shaft is 5 French compatible, features a 1.5 millimeter crossing profile on a 014 platform, and has a working length of 150 centimeters to allow treatment of challenging lesions above and below the knee. The emitter delivers up to 120 acoustic shockwave pulses that emanate spherically beyond the catheter's tip, getting IVL closer to occlusive calcium than ever before, enabling calcium cracking in front of the catheter. Shockwave JAVELIN has a proven safety and efficacy profile consistent with balloon-based IVL, which minimizes the risk of distal embolization, dissection, and other complications. Shockwave JAVELIN is IVL redefined to modify and cross calcified occlusive disease.
Hi everyone, Dr. Coral, can you go to that next slide for me? Oh, he just loves that video so much. We're going to keep playing it over and over again. Hi everyone, I'm Jen Petrie. I'm the Associate Director for Peripheral Medical Education. Welcome. If you've not done it already, we have a chat box, and I'm going to just do a quick housekeeping item, and your homework here is going to be going into that chat box. So as you know, attendees microphones, you're muted throughout the whole time, but we want you to interact, ask questions, and where to do that's in that chat box. When you go into the chat box, you're going to see a blue box. If you look at my screen, it shows where it says everyone. Make sure you click everyone when you're interacting. So instead of just coming to hosts and panelists, we want you guys to be able to see the questions you're asking so that we're not repeating questions. And Dr. Winscott, throughout this session, will make sure to be answering those questions and interacting with Dr. Coral to get you all the information you need to know. If you haven't done it already, go into that chat box. Here's a homework assignment. Click on everyone, introduce yourself, and let us know what city you're from. Without further ado, Dr. Winscott, you ready to kick it off?
Absolutely.
Let's do it.
Good evening, everyone. My name is Dr. John Winscott. I'm an interventional cardiologist at the University of Mississippi Medical Center in Jackson. And this is not an April Fool's joke. We actually do have a new IVL catheter called JAVELIN. So we welcome you to tonight's program. I'll be moderating, and we're very fortunate to have J.D. Coral on the panel as well, who'll be demonstrating the evidence behind this catheter and also showing some cases from his own practice. So without any further ado, I'm going to kick it over to JD and let him get us started, and I'll be back shortly. Feel free to ask questions. We'll try to address those as we go.
Thanks, John. I appreciate it. And Jen, I appreciate the opportunity. It's a great program here, webinar we have. I'm an interventional cardiologist from Christ Hospital in Cincinnati, Ohio, kind of specializing in CLTI and below the knee intervention. So we all know about CLTI, 4 million Americans dealing with CLTI. Treatment strategies are shifting towards a more aggressive, earlier revascularization strategy, especially for the high-risk patients, those diabetics, tobacco abusers, chronic kidney disease, because they can have rapid progression of CLTI. And we know these patients have challenging anatomy, CTOs, multi-level disease, and of course calcium, which we're going to focus on here tonight. We know calcification in peripheral artery disease can be thick, multi-level, superficial, medial levels, extensive calcification, especially in these CLTI patients. Again, the advanced age, the diabetics, the chronic kidney disease, and the tobacco abusers. This picture is a patient of mine here on the right. He was in his 40s, but he had the diabetes and the end-stage renal disease. And you can see the calcium buildup in these tibial arteries. So challenging, to say the least, on these type of patients. We know that the more calcium in these peripheral vessels, the more ischemia, the more limb ischemia. When you drill down to tibial arteries, you can look at the tibial artery calcification score, the TAC. As the TAC score goes up, the severity of limb ischemia goes up. And you can also see as that TAC score goes up, the amputation risk rises as well. We know that these calcified lesions can be challenging. They present significant technical challenges to any endovascular procedure. Again, dense calcium, CTOs, long lesions, and an extensive calcification of those tibial arteries, which can be thick, dense, and of course, long chronic occlusions down in the tibial arteries below the knee. When you do look at these tibial arteries again, as the calcium goes up, lower endovascular technical success, increased risk of amputation, and of course, increased risk of MACE. So higher stakes for sure down tibial arteries. These calcified lesions are difficult to treat, associated with early recoil, dissections, TVR, and restenosis. So successful endovascular treatment is highly dependent on proper lesion preparation and calcium modification. Calcium is a theme in these patients with CLTI. So it's a problem. It's a barrier to technical success from an endovascular approach, and it's associated with high rates of major amputations and complications. John, back to you for the Javelin in action.
Yeah, thank you, JD. So you can see that, as we all know, that calcium is a formidable barrier to treatment and just sometimes getting started in some of these cases. And so most of you obviously have probably used already balloon-based IVL, which has been a game changer in our practices, being able to deal with calcium and treat it effectively for lumen gain at the end of the case. But one of the challenges we have is just getting our equipment even across these lesions to start with, and that of course is a challenge for balloon-based IVL as well as other devices that we might choose to use for treatment. So I was just going to stop here and open up a polling question to see what your barriers are in your own practice and how often you're coming across lesions that you cannot cross either with a wire or catheter. So, Jen, if you'll launch that first question, what I'm asking is how often do you encounter a calcified arterial disease that you're not able to cross a lesion with either a wire or a catheter? And that could either be very rare in your practice, less than 10% of cases, or greater than 10% of cases. So if y'all just go ahead and vote, and we'll go ahead and look at those results and get an idea of exactly what the challenges are in your own practices.
Hey, John, I tried to vote, but it says I can't vote. So I would say it's probably about 10% in my practice.
Okay. Yeah, I think for those of us who do critical limb and limb salvage cases, I think it's going to be somewhere in that 1 to 10% for most patients, for most operators. Jim, were we able to see those results? There we go. And that's exactly what we see with the audience tonight. So nobody has it rarely, and some people even have it more than 10% of their cases. So this is exactly the problem that we're trying to tackle with Javelin. When you see that video on the left, you have a wire across a lesion but unable to pass a balloon-based IVL catheter, whether that be E8 or one of the other catheters across the lesion. And so that is the solution that Javelin offers. So if you see the video to the right, you're able to pass a wire through the lesion, and then you can actually deliver energy at the tip of the catheter that actually moves ahead of the catheter and helps you modify that plaque, modify that calcium, get those microfractures in the lesion before the catheter even gets there, so that you can deliver energy ahead of the catheter and allow it to cross. And so it's not just a crossing catheter, it is treatment as you pass through the lesion. Next slide there, JD. So this is just a cartoon demonstrating that. So if you're familiar with balloon-based IVL, you know that as you deliver energy to that vessel and create those microfractures in the calcium, the balloon then dilates at low pressure, and you see right in front of your eyes the compliance in that vessel change, because you're able to gain more volume of that balloon at the exact same pressure, which is the definition of compliance. And we're used to that. We're used to seeing that. You can remember probably your very first case with balloon-based IVL, where it almost seemed like magic, because you had the balloon inflated at low pressure, you gave it energy, and all of a sudden the balloon expanded without giving it any more pressure on the endoflator. This is a little bit different. You're actually creating the microfractures in the calcium as you pass this catheter through the lesion. It's more of a daughter effect of what the catheter does, but it is delivering that energy not just ahead of the catheter, but also to the side of the catheter. And so you're creating those microfractures, and then you're following that up with dilating the vessel. And so with balloon-based IVL, you're actually giving energy and dilating the vessel simultaneously. Where here, you're changing the compliance of the vessel and then dilating it sequentially. And so that's a different aspect of this type of IVL compared to balloon-based IVL. Next slide. So thankfully, this catheter is going to be very familiar to you because it connects to the same generator you're used to. And so the same handle. The only difference is how you flush it, and we'll go through that in just a minute. But this is really a first of its kind non-balloon based IVL catheter that helps you overcome some of the limitations of getting across these lesions with balloon based IVL. Next slide. So when you look at the anatomy of the catheter, it's 150 centimeter working length, so it's really effective for being able to treat patients all the way down into the foot from crossover technique, which is really important for me personally. I practice here in Mississippi, a lot of obesity, antegrade access comes with a lot of challenges in my practice. So I really like to be able to treat crossover and be able to reach all the way to the ankle with 150 working length. The distal 25 centimeters of that catheter is flexible and also hydrophilic coated. You can see the emitter there is 3 millimeters from the tip, and the window is ahead of the emitter. We'll have a blown up cartoon of that in just a minute. You see the catheter connects to the same connector you're used to, and it gives you 120 pulses. And of course, like I mentioned earlier, it's compatible with the shockwave generators that you already have. If you look to the right of the screen, you can see the hub that allows you to flush saline through the catheter. So you just put a stopcock on the outlet port, you hook an endoflator to the inlet port that only has saline in it, no contrast, and you just flush that through the catheter at low pressure, which allows you to have saline in the tip of the catheter and flush all the bubbles out at the end of each cycle. So that's how that works, and of course it has an 014 wire port. Next slide. This is a blown up view of the tip, and you can see the emitter is 3 millimeters from the very tip of the catheter. You have the IVL window, which you're going to fill with saline at low pressure, 4 atmospheres with your endoflator. And the emitter is going to deliver energy ahead of the catheter and, of course, surrounding the catheter. You can see this. I'm going to show you this on a case in just a minute where you can actually see the emitter under fluoroscopy, so you'll know exactly where it is and how it's moving through the lesion. And of course, it's braided. I don't think I mentioned that earlier, but the length of the catheter is braided stainless steel, which gives it really good pushability and a lot of tactile feel when you're passing this catheter through the lesion. Next slide. So this is just an example of how that works. You're familiar with balloon-based IVL, but JAVELIN's going to generate that energy ahead of the catheter and actually fracture that calcium ahead of the catheter. And I'm going to have a proof of concept case in just a minute. Next slide. So I'm going to demonstrate a case from my practice, which is actually the very first JAVELIN case that we did here in my hospital. And the history behind this patient is really interesting. He's a type 1 diabetic since teenager, so for over 30 years. He's now in his late 40s. He's an attorney here in town, has really bad ischemic rest pain and foot claudication when he walks. He's very limited, was having trouble getting through airports because of the foot claudication and sleeping at night because of rest pain. I had previously attempted this case last summer with pretty much every trick I had in the book, other than fracturing the calcium from externally using like an 18-gauge needle, which I did not do in this situation because he didn't have tissue loss, and I really reserved that for true limb salvage cases, but he had severe rest pain. I was able to get through this distal AT occlusion with a small wire, a Fielder XT wire, but after that, nothing would cross. And even after I accessed the dorsalis pedis and externalized the wire and had body floss through this lesion, I was still unable to advance even the lowest profile coronary CTO balloons, any microcatheter to try to exchange for a rotofloppy to use some type of atherectomy. It was really a stubborn lesion. And even when I locked a small profile balloon onto the wire and tried to pull the catheter through the balloon, through the lesion with the wire, which is a very usually successful technique, I couldn't even do that. It would just accordion the balloon at the lesion. It was really resistant. So at the time, I decided to abandon the procedure. This was last summer. And then in October, we did the cadaver lab with the JAVELIN catheter. And I kind of saw how it was working through these distal tibial vessels and even the pedal vessels, and decided this would be probably a solution for this patient. So I brought him back for our first JAVELIN case at the end of October last year. And you can see the occlusion on the left panel there above the ankle. He was actually initially sent to me for consideration of deep vein arterialization and the lymph flow, but he doesn't have a posterior circulation at all. So there's really not a donor vessel for lymph flow. And of course, I didn't want to steal from his only vessel in the foot for that. So we decided to bring him back for Javelin. And fortunately, I was able to get back through that lesion with a Fielder XT into the dorsalis pedis. So, JD, if you go to the next panel, you can see there we have a wire through the lesion. You can see just how dense that calcium is right above the ankle joint that was giving us such trouble before. And we advanced Javelin right up against that lesion and actually applied all our energy. We gave all the cycles, and the Javelin did not pass through the lesion, which was, of course, disappointing to us at the time. But you remember back when I treated him 3 months previous, or attempted to treat him 3 months previous, I tried every trick in the book, including a 0.9 laser that would not go through, which has been my experience with this degree of calcium. Laser has not been very successful in my hands, at least. And I really had felt like I exhausted all our options, including trying to pull those balloons through. But after giving this lesion energy with Javelin, presumably giving it energy ahead of that emitter into that dense calcium, I actually was able to pass a low-profile coronary CTO balloon fairly easily. So if you go to the next panel, you can see that's a 1.2 millimeter center marker balloon in the third panel, and then a 2 millimeter over-the-wire coronary balloon in the right panel. And we're actually able to get the lesion to give and dilate with those balloons. So after that, I was encouraged that maybe I'd be able to deliver an E8 catheter, which is my go-to catheter for these type lesions at the ankle and even below the ankle. So, JD, if you'll go to the next slide, you can see that the E8 actually crosses the lesion. We're able to get this is a 2.5 millimeter E8, and you can see it expanded. We gave a good bit of energy to that lesion and then followed that up with a longer balloon, low profile. That's just a 2.5 by 150 millimeter nanocross. And so you can see even at low pressure, it expanded really well. And you can see on the final angio, we now have straight line flow into the foot. I'll be the first to admit, not a perfect result, but a much improved flow into his foot. And actually, when I saw him back several weeks later, and then I've now seen him back for a 3-month follow-up after this procedure, he remains markedly improved clinically and has very little claudication. He was able to walk through the airport. He has no rest pain. He's able to sleep at night. And we're going to keep a close eye on this lesion with duplex. But at his 3-month follow-up, he had an easily palpable dorsalis pedis pulse. So that's just kind of a proof of concept demonstrating how this catheter actually does deliver energy ahead of the tip of the catheter, which in my practice was really important to me as a new concept that I've been unable to do previously with balloon-based IVL. So with that, I'm going to turn it back over to JD, let him talk about the study we did with forward PAD with Javelin, and then show some cases.
All right, John, great case there, great case. So the forward IDE and the feasibility studies, 90 patients enrolled at 19 sites, total of 103 lesions. These were moderately calcified lesions, Rutherford class 2 to 5, stenosis greater than 70% below the knee or 90% above the knee, lesion length less than 150. This excluded cutting balloons, scoring balloons, reentry devices, atherectomy, and of course, no in-stent restenosis. So the primary safety endpoint was a composite of cardiovascular death, CD, TLR, and unplanned amputation above the ankle. And then the primary effectiveness endpoint was technical success defined as less than 50% stenosis with no flow limiting dissection. And you can see when you look at the safety profile, excellent safety profile, 98 lesions in that composite over there. You can see one dissection out of those 98 lesions, no perforations, no embolization, no episodes of no reflow, no abrupt closure, no thrombus. So excellent safety profile in some tough lesions. And you can see it really mirrors the balloon-based IVL safety profiles in those respective trials as well. You can see the safety profile outstanding across the board. This is what we've come to enjoy in clinical practice as well with the balloon-based. And I've seen it with the Javelin, haven't had any issues even post-approval, but you can see in the trial, excellent profile. When you look at effectiveness, again, you look at the charts with the balloon-based IVL, it really mirrors Javelin chart. Of course, they squeezed in that pink column, which is just the post-Javelin stenosis, which you can see there is lumen gain after just a Javelin before the balloon angioplasty. So that was sort of a pleasant surprise to see that lumen gain. It's obviously modifying that calcium and creating a channel even before the balloon. But if you take that out, the charts look very similar compared to the balloon-based effectiveness for IVL. When we look at some procedure details, a few things jump out. The device success, which is defined as getting the device in the body to the lesion, across the lesion, which is, of course, the main issue, and then, of course, out of the body. That was 93% successful. So very successful in some tough, obviously heavily calcified lesions. As far as needing an additional balloon-based IVL after the Javelin, that was only in about 25%. You can see 74%, the vast majority, got by with just Javelin to cross and modify. And then we already talked about safety with no embolization, but there was some filters used in some early cases that didn't show any debris or embolization. So I'm going to talk a little bit about patient selection. Again, you can see these patients in the office and kind of have an idea who's going to have these calcified lesions. Of course, we talked earlier about CLTI patients in general have a lot of calcium, but when you throw in diabetes, kidney disease, and smoking, you can anticipate some significant calcium in these vessels. Some pre-procedural testing can also give you an idea. Obviously, ABIs with the non-compressible vessels, CTAs, prior angiogram reviews, you can see the calcium, and of course, x-rays. So you can get a heads up that these patients may have a lot of calcium that needs to be dealt with. Then, of course, in procedure, the angiogram, fluoroscopy in this frame here. And, of course, IVUS, I routinely use IVUS, and that really lays out the calcification, the density, and the distribution. So in the case as well, you can get an idea, who's going to benefit or who's going to need IVL. So as far as the treatment algorithm, obviously access is driven by your approach to these CTOs, whether you're coming retrograde or antegrade. To cross a lesion, it's a wire question as well as a gear question. You got to get the wire across, and then you got to get your equipment across, the catheters, the IVUS balloons, IVL catheters, atherectomy stents, whatever it may be, and that can be an issue in these difficult to cross calcified lesions. So when you get to lithotripsy and you decide that's an appropriate or beneficial therapy, I kind of look at the vessel anatomy, the size, above the knee with the larger vessels and below the knee with smaller vessels. And I think above the knee, I favor the balloon-based IVL. If I can get an E8 there, I think that's going to give me my best modification. But there's a lot of those lesions that you just can't cross, and I think the Javelin can be a benefit there. Below the knee in the smaller vessels, I favor Javelin. My algorithm is shifted to Javelin in most of these cases. I'll just modify and cross that tibial artery all at once with the Javelin. Of course, if they're longer lesions or multiple tibials, you have to kind of manage the pulses because you have 120 pulses total. But it has simplified my algorithm, especially below the knee.
So JD, we actually have a polling question to kind of see what our audience is using, especially below the knee. So Jen, if you could pull up that polling question about treatment strategies below the knee and tibial vessels. What we're asking is your most often used treatment strategy for treatment, not just crossing, but treatment of infrapopliteal disease, whether that would be POBA or specialty balloons like chocolate or Serenator, whether you're using a lot of drug-eluting scaffolds, which would include the new bioabsorbable stent, of course, that's newly approved, whether you're using a lot of atherectomy devices or using balloon-based intravascular lithotripsy, assuming you don't have Javelin available to you yet. So we'll open that up to polling. JD's kind of already talked about his treatment algorithm. For me personally, I have a lot of faith in the E8 and the balloon-based lithotripsy. I'm reserving Javelin more for those really difficult tibial lesions that I don't think I can deliver E8 across. But for lesions that I feel like I can get E8 across, I'm using a lot more E8 than I do Javelin below the knee. But that's my own treatment algorithm. I think both approaches are equally correct, but that's just my own treatment algorithm. So Jen, let's look at the results of that poll and see what our audience is using below the knee. So you can see there's a lot of POBA and atherectomy, a few operators using drug-eluting stents below the knee, and then not that many people using intravascular lithotripsy below the knee. So Javelin's potentially a new catheter that would open that up to you, especially the atherectomy users who are using atherectomy when they don't think POBA is going to be the right answer for that patient due to recoil. What I've seen with especially balloon-based IVL is you obviously get a lot less recoil of that vessel even in long term when you bring that patient back for either the other leg or to do additional work, and fewer dissections like what we've seen in the trial. And that's what we saw with forward trial that JD just went over, with very few dissections and no embolizations and no perforations. So the safety profile of below knee IVL, both balloon based and with Javelin, is well established. So thank you for your responses to the poll. We're going to move on to some cases with JD.
All right, great. So case one, this will be a below the knee case. Again, I think this is kind of the wheelhouse for these devices, the Javelin device. So 59-year-old female, Rutherford 5 PAD, left lower extremity. You can see the amputation of the great toe there. Diagnostic angiogram was right common femoral access up and over, and then ultrasound guided access in the AT and the PT. You can see the angiogram, just single vessel runoff through that peroneal, and then occlusion of the PT and the AT. I'm going to focus on the AT for this example because that's where I use the Javelin, but you can see in that far right panel we got access in both vessels. And then you can see in the left panel, this is a reverse cart from above with the balloon from above, got the wire across the proximal part of that CTO. And I was able to sneak it into the sheath without a snare, but usually we like to floss these and get control from both sides. So we were able to slide it right into the sheath. And then I just slide a spare sheath inside the diaphragm of that destination sheath, and not just externalize that wire through that sheath. And then I was able to IVUS the lesion in the AT, got our measurements. See if I can get off this slide. And then from below, you can see the Javelin in the distal, the mid, and the proximal segment. This is about the speed I go, about a millimeter a second, I think is kind of where I've landed as far as a pace on these. And you can see in that fifth panel there, the post-Javelin, you can see the lumen gain just with Javelin. There's been no balloon angioplasty. So you do create a channel, and you do get some lumen gain just with that modification. And then we brought our balloon from above. I like those tapered balloons, 3.5 tapered and a 3.0 taper based on our IVUS measurements. And then again, you can see the pre-Javelin, the post-Javelin, post-angioplasty, and then you got the angiogram all the way down the foot. You can see the flow out to those toes. This is just after we treated the AT. We went on to treat the PT too, but the Javelin was used in that AT.
JD, that's a great case, and I think it brings up an important point. You talked about the use of IVUS not just to identify the location and extent of calcium, but also in sizing your tibial vessels. I find that to be a real challenge with my fellows. I train both cardiology and vascular surgery fellows, and sizing tibials tends to be a challenge for both groups, even though the cardiology fellows are familiar with sizing coronary size vessels. So we actually have a polling question about the use of IVUS with our audience. So Jen, if you could pull up that last polling question we have about the use of IVUS, just let us know kind of how often you're using IVUS in your leg cases, your infrainguinal. So we're going to leave out aorta. That's a whole different ballgame. But for infrainguinal cases, how often are you using IVUS? And I just define selectively as less than 10% of your cases, or kind of moderate use would be 10 to 50% or more than half your cases. So JD, you said you pretty routinely use IVUS. So what do you consider to be routine? Is this most cases for you?
Yeah, I think pretty much every case. Now, the only exception if you're radial and you're using some of the Sublime equipment with the 250 shafts, obviously you're not going to reach with IVUS. So those you're limited there. But if I can get an IVUS there, I don't think it's a big deal. We're so used to doing it. It's like 2 minutes to set up and 3 minutes to. It's literally 5 minutes of time. So we get a ton of information. And I talked about my algorithm with going straight to Javelin. if you go straight to the E8, sometimes you can't get that IVUS down there, and then you're kind of guessing on your E8 size. You've probably got trained eyes for that, and it's probably pretty accurate. But I'll javelin that, and then I'll IVUS because I've cleared the way, and then that allows me to pick those balloons. Those tapered balloons. It's 3.5 tapered and 3.0 tapered for that last case. So it really helps you, get your IVUS through there, and then you can get accurate measurements post javelin.
That's a great point that we really hadn't made up to now. That if you cross with your wire and then lead with javelin, then you can IVUS behind that on these difficult to cross lesions and then choose your appropriate size balloon. Where if you were going to go in with E8, you really need to choose E8 sizing appropriately from the get go. And if you don't have an idea of how large that vessel is, you could choose inappropriately. And we all know how important sizing is with tibial vessels. I do tend to oversize. The recommendation, of course, is 10% oversize for all vessels, including tibials. But I find that to be especially true in these calcified tibial vessels to use the appropriate size balloon-based IVL. But with javelin, you really don't have to worry about that. You can javelin through the lesion first, and then based on the angiography of the now open vessel or more open vessel after javelin, you can make a more informed decision for balloon choice, or you can IVUS, like JD mentioned, and get that. So Jen, if you'll show the results of our poll, I'm just curious as to how often our audience is using IVUS. So more selectively, which is my own practice, but a third of guys are using it more than 50%. So a lot of IVUS use overall, but there is a lot of information to be gained from IVUS. And JD, why don't you just give us a couple other examples other than vessel sizing, where IVUS kind of helps you make decisions in your cases?
Yeah, so I did a case today that it was just a rock, and we got around sort of the side of the rock. So number one, I want to see if I was true lumen, which fortunately we were, and also you get an idea how eccentric these plaques are, and what kind of benefit you're going to get from IVL, or if there's something else that might be more beneficial. You get, if there's more morphology to the plaque than just calcium, with thrombus, etc. So I think there's a ton of data, especially with restenosis. A lot of times you'll see undersized stents that are in SFAs and even tibials and iliacs, often undersized. So I think IVUS gives you a better feel for all that stuff. It's free. It's free. There's no contrast. There's no X-ray. So you're just getting information without any of the.
Yeah, I think you bring up an important point about restenosis or stents that are already in place. And of course, we're entering an era where we're going to have stents below the knee that we can't see angiographically with a spree. And so I think it's going to be really important for us to be able to image and see exactly what's going on in that vessel when we're limited by fluoroscopy and angiography. So yeah. Excellent discussion about IVUS. Let's go ahead and move on to your next case.
Another below the knee here for you, John. This is a 82-year-old, Rutherford 5, right lower extremity. Here's your diagnostic images via antegrade right femoral axis. You can see the AT diffuse disease, the PT 100% occluded. The AT occludes distally, and the PT occlusion extends down into the plantars. And you can get a sense of the heavy calcification as well with fluoroscopy. So on that left panel, you can see the javelin. We were able to cross antegrade, which was fortunate in this lesion, all the way down to DP. And you see the javelin working its way down that AT. In that middle panel, I did take it, below the ankle and down into that anterior tibial artery. And it does go. It's very flexible, and it can navigate in those small vessels. And then I used another tapered balloon from above. So we were fortunate to cross this antegrade. It's not always that lucky on those. And then you can see our results. We did a selective shot through the balloon catheter. You see that AT opened up nicely, pulled the catheter back and took a little higher shot there. And again, the AT is flowing great. And then I brought that down and did a foot shot. So you can see you got great flow out to the toes on that dorsal pedal. So then we turned our attention to the PT, and again, got lucky. The wire did cross antegrade all the way down. And you can see the javelin there in that left panel. Oops, sorry about that. And followed that up with balloon angioplasty. Again, tapered balloons after IVUS to get the sizing. So these vessels, in my experience, are always bigger than you think, and got a 3.5, 210 in there, 3.0, and a 2.5 and a 2.0 down distally. And we put the catheter tip down there and took a shot of the plantars, which opened up nicely. Fortunate there. And then you could see the panels 2 and 3, the post angioplasty images of the tibials, and then you could see the pre and the post over there. So we got all 3 vessels opened up. Well, we got 2 of them opened up. The peroneal was already there, but this improves flow out to that forefoot from both the PT and the AT distribution.
So JD, I know you use a lot of the tapered tibial size balloons, and I do as well. But I think that also brings up a good point about Javelin versus balloon-based IVL that we were mentioning earlier with IVUS is about sizing. And so it's not uncommon that you encounter a vessel that's significantly smaller distally than proximally, especially in these lesions that we're treating the vast majority of the tibial. So these are lesions that are not involved in these clinical trials like Esprit, with Life BTK, where they're treating 4 to 6 centimeters of the proximal tibial. We're treating a lot of times the entire tibial, and there may be a significant size mismatch, especially in the perineal, where it's after it gives off the muscular branches to the gastroc and the soleus, it can get significantly smaller unless it has a lot of collateralization from the distal vessel. So I think that's also an advantage of Javelin, is that you can cross through and treat all of that with the same catheter and not either oversizing your balloon-based IVL distally or significantly undersizing it proximally when there's size mismatch between the proximal and distal vessel. So I think that's an important point to think about when you're treating long tibial disease.
Yeah, they're definitely tapered, so you will be dealing with different sizes as you go down. I'm going to get into a couple above the knee cases. Again, I think there is some use up here. As I stated before, I tend to favor the balloon-based stuff up here if you can get it there, but some of these patients have significant calcification. It's just tough to cross. So this is a 93-year-old Rutherford 5 right lower extremity. And here's your angiogram. I'm going to focus on the lesion in the common femoral. She also had SFA, POP, and tibial disease, but this is a good example of where the Javelin can be used in a above the knee location. So in that left panel, you can see we did round 1. If this will play, let's see. And you can see that dense calcium there in that common femoral. And we just slowly worked our way through. And then on round 2, we, on the right side there, we ultimately popped through. And we were able to make a channel. We ran a couple more runs through there. We did save some shocks for the tibials, but we got what we needed up here, and then we were able to IVUS. And you can see that slit that it created. Again, this was subtotally occluded, so we did create a little channel. We were able to slide our IVUS through there, get some measurements. And then I brought in the E8. Again, not ideal to use 2 IVL therapies, but these cases can be tough, and we treated multi-levels on this patient. I got some mileage out of this E8 in the POP and SFA as well. And you can see after Javelin plus E8, we got a great result up here. And this could have been a very complicated common femoral artery. We just needed to get down to the SFA and POP and tibials to get some work done, but we didn't want to get hung up here. So we were able to get through pretty clean, pretty quick, and got a great result with, again, you don't need any complications in this area. You don't need dissections or perforations. So it was nice to get through clean and then get to work downstream. So I do think, getting across this with the Javelin was key, because the IVUS wasn't going, balloon catheters weren't going, so we had to create some type of channel just to get going. I'm going to show you another above the knee case. Again, mostly tibial stuff, but there are these select cases where I think it's beneficial. This is a popliteal lesion, 74-year-old, Rutherford 5, right lower extremity, diagnostic angiogram via right radial access. And you can see we tried to cross this with we got tibial access in the AT, tried to cross this with the IVUS catheter, and it would not cross. So that gave us a clue that we're not really going to get through this. So I got the Javelin out from below, and you can see in that left panel is round 3. So we had parked it on this cap, and just let it work. And you can see the catheter jump across, but you can also see the forward pressure where the catheter bows there. And then you can see in round 4, after we've crossed, much less force on the catheter as it slides through there and modifies that plaque. And then we were able to get our IVUS catheter across post Javelin. You can see you actually have a little lumen there to slide through, whereas it wasn't crossing before. And then we did bring out an E8 again after the IVUS. Again, I favor the E8 up in these vessels. Not ideal to use 2 IVLs, but again, these are tough cases, and sometimes you have to. 6x80, shocked the whole popliteal, and then we did a 6x150 Ranger DCB, again delivered from AT Access. And then you can see your pre and post there. Excellent result. Again, an area that, John, you don't want a complication down here. You don't want to have to bail out stent or anything at the joint space. So it was nice to get through with the Javelin, modify at low pressure, and then DCB and get out of Dodge.
Yeah, I think that's a really important point. I think most of us would agree that that area of the popliteal especially is what I would consider a no stent zone. And a lesion that tight is at risk for dissection, even trying to pre-dilate that lesion with a small balloon just to deliver your E8. And so E8 is probably not going to go across that lesion without some type of pre-dil. And so what you did was use 2 different IVL catheters, which some people might think that would be excessive, but in this situation, you were able to get just an outstanding result in a patient that cannot afford to have any distal embolization because they have tissue loss and poor runoff, and you don't want to put a stent in this area. And so I think when you're trying to make decisions on the front end of how this case is going to be at the end, and not having to place a scaffold, my goal there is, of course, a stent-free vessel. And so whatever it takes to do that, I think putting all the tools in your toolbox to accomplish that. And I think this is a great example of that. And E8 performed very well, but you've got to get it there.
Yep.
And if you'd had to pre-dilate this with a 3.0 or 3.5 to deliver an E8 through there, it may have dissected before the E8 even had a chance. And of course, in a clinical trial, a dissection is a dissection. It doesn't matter what caused it; it's what you have at the end. And you end up with a bailout stent in that situation, and that patient's got a problem they're going to have to deal with for a long time. So for this patient, what an outstanding result to be able to get an E8, a DCB, have a stent-like appearing vessel at the end, likely stent-like patency as well, without having to worry about that scaffold for the rest of that patient's life. So excellent case there. I'm going to ask Jen if we have any questions that have rolled in for the audience. Really great cases, JD. I think you demonstrated really well how Javelin can be used in a variety of scenarios, both above and below the knee, from antegrade and retrograde access. How you've used it in tandem with both balloon-based IVL and with POBA, and of course with drug-eluting technology in the places that we have that FDA approved currently, which is the film pop segment. So any other further comments that you have before we wrap up?
No, I think I think we covered a lot of ground here. I'm obviously a big fan of the device. I've had a lot of success with it. It's made my job a lot easier, which is key. I mean, these are tough vessels, so anything to make it easier, I'm all for. And this has been a big plus for my toolbox for sure.
Yeah, I think it's really important that this is riding on the coattails of balloon-based IVL with the shockwave catheters we've had up to this point. They've just demonstrated ease of use and safety, in addition to the efficacy and allowing us to do cases that we really couldn't do very well prior to this technology. So it's really been a game changer for me personally in my practice, and not just necessarily made cases easier, but allowed me to do cases that I couldn't have done otherwise, and that patient would have been facing amputation without us being able to recanalize a very difficult calcified vessel. So Javelin is just going into that same toolbox with the other IVL catheters that I have, along with atherectomy, along with drug-eluting balloons, as really powerful tools that we have in our armamentarium to tackle these really complex cases as we move forward. So I'd like to thank everyone's attention. I'd really like to thank JD for sharing with us his expertise in this area and demonstrating the cases from his own practice. I'd like to thank Shockwave for hosting us tonight and allowing us to share this new catheter and this information with the audience. And happy April Fool's Day. See y'all later.
And Dr. Winscott, on that note, there was someone was going to fool us, but then they got a question in, so we did
Oh,
get a
they
question.
the
I wanted
last
to make
minute.
sure. Dr. Hun asked, "Have you experienced any window rupture, and what did you do?"
So JD, I'll let you handle that first. The question was, in your experience with Javelin thus far, have you had any window ruptures with either prepping the device or in the body?
Yeah, I've had two. One was a prep, which was really my fault. We had a new tech, and we were prepping it, and you need to flush all the way through that loop the first time. So you connect, you open up the stopcock, and you just turn it up to 4, and it takes a while to flush all the way through to get a drop to come out. Once a drop comes out, you turn that knob. Well, this tech, when you watch a balloon, you just keep going up till you see the balloon, and she just kept going up, waiting for that bubble or that drop to come out. So she went up to like 12 or 14 as she's looking and just ruptured the balloon. So that was my fault. We should have been a little more clear on it. You just need to wait and let it go. But she thought the higher we go, the faster it would come around. It just ruptured the balloon. So that was my fault. We also had a case that we were near the end of our 120 pulses and we had a rupture. And it's going to happen. I mean, these are heavily calcified lesions. So you're going to have balloons rupture. You're going to have these windows rupture just coming in contact with these calcified lesions. So I've had two um, early cases that have had ruptures. One was my fault. One was calcium driven.
Yeah, and prepping is really important. Of course, your reps will help you with this. As you pressurize the circuit at the beginning of the case to get it flushed through, it's just really important to be patient and allow that saline to flush through the system. Like JD was mentioning, I just go to 4 atmospheres and just hold it at 4 until it cycles all the way through. I do it myself. I'm a little bit of a control freak, I guess, when it comes to that to avoid problems. But I just flush it through before I put it in the body. That way, I'm the most familiar with the catheter, so that's what I do. And then, of course, you can have a risk of rupture of anything inside the body because of these lesions. I mean, you've got all these stalactites and stalagmites and coral reef calcium just waiting to grab things. That window is a very non-compliant material. It's difficult to rupture it. I've tried to do it outside the body, and it is very resilient. But it is possible. But actually, I personally have not had any ruptures to this point. Knock on wood. But I'm sure I'll have one tomorrow now that we've talked about it. But great. Any other questions, Jen, before we wrap up?
Those are the questions. And before we wrap up, I want to give a big shout out to the two of you. I know you're giving thanks to Dr. Coral, but thank you to Dr. Winscott for the fabulous moderation, Dr. Coral for the fabulous just walking through the presentation. Both of you guys talking through your experiences. They are very important, and we appreciate you going through those tonight. So thank you for doing that. If anybody has any further questions, feel free to reach out to me, and I can get a hold of these guys and get the questions answered. But thank you all. Anything else you
Thank
guys
you
want
all.
to add in?
I think that'll do it. Thank you very much, Jen. Appreciate you hosting. Y'all have a good night.
Have a
Thanks,
good night.
everybody. Thanks, Jen. Thanks, John.